people around the world opening up. We have Great Britain saying we want to live with COVID. Right here in New York City, we have the mayor saying he can't wait to do away with mask mandates, with vaccine mandates. What is the risk we're moving too quickly away from masks and vaccine mandates?
Well, if you look at the current guidelines of the CDC, where they're basing their guidelines on cases alone, as you probably have heard, they will be essentially updating and modifying the metrics for their guidelines. In other words, not just relying on cases, but relying on severity of disease, particularly hospitalizations, as well as hospital capacities in a given location, such as at the county level. If you look at that right now, pulling back on masks is a bit risky. However, if you look at the curve, how sharply it's coming down on a daily basis by a certain percentage each day in both cases and hospitalizations, we are clearly heading in the right direction. The real question that we're all going to pay attention to is that when you pull back on mitigations like masking requirements, be they in indoor places, workplaces, or the schools, what is going to be the reaction of the virus to that? Is it going to continue to go down? Is it going to plateau as opposed to keep going down? Or is it going to rebound? It is somewhat risky, but I believe if we keep going in the right direction with the cases going down, then there will be an epidemiological justification for doing that. But it's just right now, just at that transition zone where the prediction of pulling back might actually be the right thing, given the next iteration of what the CDC will be recommending based on their new metrics, which I think will make the country look on that map of guidelines, look like there's less of a risk in certain areas than was previously thought, according to the prior metrics.
So, Dr. Fauci, staying with the CDC guidelines, my understanding is the CDC now is changing their recommendation about the time between the first and second shot in the vaccine up to 8 weeks, apparently because of some concerns about myocarditis. My question to you is, are there data that actually indicate you get a better response, more effective immune response, also by prolonging the time between the first two shots?
David, there is a balance to that, because if you get the first shot and you wait longer for the second shot, you have a risk of not being vaccinated to the full primary component for an additional few weeks. That's a small risk, but a risk. If you wait a bit longer and you're in that younger age group where you actually have a risk, a young man, for example, between 12 and 39 years old, has a small risk of myocarditis that you make even less of a risk when you push out the second dose. But knowing that from prior experience, for example, in England, you may get a better initial response if you give the immune system a couple of more weeks or so to mature in its response. So it's a balance. On the one hand, it could make it a bit better. On the other hand, it can give you vulnerability in those first few weeks following your first dose. So I don't think it's going to be a substantial difference in efficacy by any means, but the CDC made that recommendation because they wanted to make the risk of a very low adverse event, i.e. myocarditis, even lower by extending the time.
Dr. Fauci, there's a lot of talk, of course, about preventing getting COVID. There's also the other side of this, which is for those folks that do actually get COVID, the treatments out there that are available. There was a lot of talk when that Pfizer pill was introduced, Paxlovid, that this could potentially be a game changer. Those were the exact words that we heard from the President of the United States. We're a few weeks into this now. How are we doing with regards to A, availability of that pill, and B, the effectiveness of it in treating COVID?
Well, we're going to have a lot more available as the months go by. Right now, obviously, it's somewhat limited. There's enough out there, certainly, to get the people who would need them at the high risk. Remember, if you look at the data show very clearly that if you are within a high risk group and you get infected, it prevents by about 89% the likelihood that you will progress for the need for hospitalization and ultimately dying. That doesn't mean that everyone who gets infected, particularly when you're dealing with Omicron, when it looks like in general, the risk of hospitalization and death on a case-by-case basis is less. So A, we have a limited amount, but enough to go around for the people who likely need it. And as the months go by, we're going to have even more. There'll be a lot more. There'll be 20 million doses.
How confident are you that that more is also going to be effective against additional variants out there?
Well, you know, if you look at the variants and how they actually evade immunity from the vaccine and evade immunity from the monoclonal antibodies, it's much more difficult from what we've seen so far for those variants to evade the effect of a direct antiviral. It could happen. We've seen the evolution of drug resistance, but given the fact that that antiviral drug acts at a part of the replication cycle that's really a different story than that binding site where the virus binds to the cell, and sometimes when the virus mutates, the antibody is no longer effective, or is the antibodies that are induced by a vaccine. So I think there's less of a chance of that happening, but we know from experience, for example, with anti-flu antivirals, that the more you use them, particularly if you use them over a prolonged period of time, you can get the evolution of resistance, which is the reason why we don't want to stop just what the antivirals we have. They're going to be very, very useful, as you say, in some respects, a game changer. But we want to continue to both discover and develop additional ones so that you have a larger armamentarium available for the people who need them because they're at a greater risk of progression.
And so, Dr. Fauci, when we talk about, I guess, what other options are out there, what other options are available with regards to whether it's vaccinations or other sort of preventative measures here, we're going mask off now, at least in many cities here. We're now starting to see even some of the vaccine mandates start to be dropped here. So what protection, I guess, do we have, can we count on?
Well, one of the things that I think is an important message to get is that particularly when you look in the era of Omicron, that third boost that we're talking about is really something that makes a dramatic difference in reconstituting the waning immunity. You know, the good news is that we have vaccines that are highly, highly effective and quite safe. But the reality is that the protection over time wanes. We see that particularly in a situation where the protection to begin with Omicron is not as good as example against Delta. And it does wane, which is the reason why we tell the people who've been vaccinated to please, when your time comes up, to get that booster shot. We tell the unvaccinated to please get vaccinated. The data are so clear. When you look at hospitalizations and deaths, the curve of the people who've been hospitalized who are unvaccinated, the people who are vaccinated, and the people who are vaccinated and boosted, that the overwhelming percentage of the people who are in hospitalized IC units and die are among the unvaccinated. So we have a very effective tool. So if you combine vaccination and, as you said, the availability of good antivirals, such as Paxlovid, among others, it's not the only one, newer monoclonal antibodies that we will continue to develop, and the wide availability of tests, particularly at-home 15-minute tests, I think we are in a much, much better position right now to deal not only with the ability to pull back on mitigations, but also in case we get, which we very well might, so it's a big caveat, another variant. So very, very much better prepared right now than we were, example, a year or so ago.
Dr. Fauci, you said the data is there for that third shot, the booster shot in addition to the two. What about for a fourth shot? There's a lot of talk about that. Do we have data that indicates whether that's effective, particularly for the elderly or the more vulnerable, and how much more effective is it to have the fourth shot?
Well, when you have waning immunity, you look now, for example, 4 to 5 months following the third shot of an mRNA, the hospital protection still remains high at around 78%. But it waned a bit because, remember, it was up there at around 90+%. So it's down still at a pretty high level. So that's the reason you've heard me and others say, for the regular person, you really don't need right now a fourth boost, except if you have a severe degree of immunocompromise, such as transplant patients and patients who are on chemotherapy for cancer. That's for the people in one category. For the people who have no underlying conditions, we have to keep an eye out on that 78%. That's good. That's at 4 to 5 months. So on a month-by-month basis, the CDC is following whether that durability of protection against hospitalization stays steady at around the 70s, or if it keeps coming back down. If it comes back down, at some point, you'll have to make a decision. Do you want to give a fourth dose to the most vulnerable? And obviously, those would be the elderly, those who have underlying conditions, those who are at a greater risk to get a serious outcome. So really what we're doing, David, is we're monitoring it on a month-by-month basis.
Dr. Fauci, I would like to turn to a slightly personal issue, and that's Dr. Paul Farmer. I know that he was a very close friend of yours. I knew him reasonably well, spent time with him. It does strike me we have lost a towering figure in the healthcare system, and particularly public healthcare system. Reflect for a moment on what his death means and what we could learn from what he did during his time here on Earth that could inform both this pandemic and other things coming up down the road.
Well, Paul, as you're right, was a very dear friend of me and my family, my wife and my children. He's truly a once-in-a-lifetime person for so many reasons. I think people maybe not fully appreciate the total breadth of why he was such a great man. First of all, his passion for equity. He personally not only was an advocate for people in the lower and middle income countries such as Haiti, where he spent a lot of time, and Rwanda and other low and middle income countries. The passion to make equity for health care was extraordinary. But not only was he an advocate for it, he lived it. He went to Haiti and lived there. He has a home in Haiti. He goes out into the wild, as it were, to visit patients in their own home. He was totally beloved by people in Haiti. The same holds true in Rwanda. That's one part of him. Equity, a compassionate physician. But look at the things he did. He built a first-class medical school hospital in Haiti. First class. Everyone said it could not possibly be done, that you could do that in a place like Haiti. He trained Haitian nurses and Haitian physicians so that they could be self-sufficient on their own. He just recently built and is the chancellor of an Institute for Global Health Equity in a rural part of Rwanda. When you think of that, that's totally amazing. And then superimpose upon that a person who had such love for humanity. Everybody who came into contact with him absolutely loved him. Truly an extraordinary man, an irreplaceable loss to the world, to global health, and to the idea and the passion that we should all have for equity. It's just, I mean, it took me a few days to just even be able to talk about it. It was so painful to realize that we no longer have Paul Farmer among us.